皆様ご参加いただきありがとうございます。本日は横浜リンク J ライフサイエンスラウンジ Nyc 第2回セミナー、米国のエキスパートが語る医薬品サプライチェーンの現状をニューヨークにあります横浜市米州事務所と東京日本橋のリンク J オフィスからライブでお届けします。スピーカーのうちニューヨークから3名、東京から1名がオンラインで日本のライブでオンラインで日本の皆様にお届けします。また、ニューヨークの会場には10名ほどの方にご参加いただいています。私は本日の司会を務めます横浜市米州事務所の矢沢と申します。本日は画面にお示ししている本日は画面にお示ししているプログラムに沿って進めてまいります。皆様から、のご質問はウェビナーの Q&A 機能からお願いいたします。ご質問の際は、どなた宛てのご質問か明記していただけると助かります。時間の都合でご質問を取り上げられないこともございますので、あらかじめご了承ください。なお、事務局からのお願いが2点ございます。ウェビナー終了後にアンケートフォームが表示されますので、ぜひ本日のイベントのご感想をお寄せいただきますようお願いします。また、ウェビナー中の録音、録画、画面キャプチャーなどはお控えください。講演に移る前に横浜リンク J ライフサイエンスラウンジ Nyc のご利用についてご案内いたします。横浜市は産学官金によるライフイノベーションプラットフォーム、略してリッピ横浜を中心に、健康医療分野での持続的なイノベーション創出に取り組んでいます。そして横浜市米州事務所では、ライフサイエンス領域での日米の情報格差やネットワーク格差を埋めるお手伝いをしております。横浜市の事務所ではございますが、日本全体を視野に入れて活動することが、ひいてはしない経済に還元できるとの考えからかねてより、リッピ横浜を通じて連携関係にありました、リンク J とタッグを組み、2020年、22年10月に横浜リンク J ライフサイエンスラウンジ @NYC を開設しました。本ラウンジは横浜市内企業の皆様に加えて、リンク J 会員の皆様もご利用いただけます。ご利用、ご予約方法については、横浜市米州事務所のホームページでご確認ください。本セミナーも横浜市とリンク J との連携でお届けしております。それではここから NS ファーマでサプライチェーンディレクターのスティーブン・プロジャンスキー様よりご講演いただきます。スティーブンさんはコーネル大学卒業後19年間主に製造や卸売の分野でヘルスケア業界に携わり、サプライチェーン、マーケットアクセス、ライフサイクルマネジメントなどに精通されています。本日は米国の医薬品サプライチェーンをテーマにご講演いただきます。それではスティーブンさんお願いいたします。スティーブンさん、floor is yours.
Thank you. Ohayo gozaimasu. Stephen Projansky desu. Yoroshiku onegai shimasu. So I wanted to start out by telling everyone that I had the pleasure of visiting Japan in November, and I had a great time spending a few hours visiting Yokohama. So we're going to talk about a lot of topics here, but I wanted to start out with some of the really key messages here. That being, the first is you want to choose the right model for your business. Some companies will want to license their products to companies that are already doing business in the United States, but others may want to commercialize the products themselves. There's a lot of complexity within the US market. But the key message here is you do not need to understand everything completely. No one person will know everything. And you must also be willing to invest in your business to succeed in the US. It's very important that you have the right resources and the right people. And most importantly, do not get discouraged when you see the complexity of the US market. You can hire US experts to help you if you need, and you can succeed in the United States. There are some key differences between Japan and the US. There are many, many differences, but I wanted to focus on a few of them. The first being payers. The United States does not have a single payer system. We have many, many different insurance plans, and they set their own drug formularies. In fact, 75% of insured people in the United States are covered by plans that are managed by commercial insurance companies rather than the government. Pricing is also very different here. Prices are not set by the government. Prices are set by the pharmaceutical manufacturer, but then they negotiate discounts with payers. There are some mandatory discounts to Medicaid, but states can actually negotiate supplemental discounts there as well. Also, provider reimbursement. So payers negotiate the reimbursement of drugs with the provider, which we're talking about the pharmacy, the hospital, or the physician's office. And there are many different methods of reimbursement. And a provider can get paid different amounts from different payers for the same drug. Also, in terms of patient responsibility, there are a lot of differences in what each patient has to pay for the same drug. So providers will determine the cost of the drugs and services, and they negotiate that with the payers. And then the payers determine with the plan sponsors what the patient's actual financial responsibility will be for a drug. So for example, if there's a copay or co-insurance, what that amount will be. So one patient can have different costs than another patient for the same exact drug. The US market is really, I think, undergoing some transformations right now. We have new types of therapies being created. We used to focus on small molecule drugs and trying to find the next blockbuster drug. But now there's a big focus on rare diseases, cell and gene therapies, and personalized medicine. The focus of the US healthcare system used to really be about caring for the sick. But now it's more about population health and managing wellness. Therapy selection, the drug selection used to really be decided by the individual provider on his or her own experience with a small group of patients. And now we're finding health systems creating system-wide therapy protocols. And we're moving more towards value-based pricing in the market. And then, of course, on the patient experience, we used to focus on the product and on sales and very basic patient services. Now there's more of a focus on the patient journey. It's really important to understand what are these patients going through as they're going through the disease state, but also in their journey to get their therapy, because you need to address those services with those services that you can provide. How can you address their challenges? In addition, there's a lot of consolidation going on in the US market. So for example, health systems are purchasing pretty much everyone. They're purchasing hospitals, other health systems, physician practices. Over 50% of physicians now work for health systems. That's very different than it was about 10 years ago. We have PBMs, and which is a type of payer, buying other PBMs, buying health plans, buying pharmacies. We have wholesalers buying pharmacies. We have pharmacies buying wholesalers. There's a lot of consolidation. We also see a lot of vertical consolidation. And here's an example of some of the largest payers and how they're aligning, how they're purchasing different companies in that vertical alignment. And what we see here is that most of these cases, they're actually purchasing these companies, but in some cases, they're negotiating partnerships. So I wanted to provide this to everyone. This is the US pharmacy and distribution and reimbursement system. This is sort of the flow of relationships, the drug flow, money flow. The important things to focus on here as a manufacturer would be the manufacturer relationship with wholesalers, pharmacies, and the payers. which payers we include third-party payer health plans, as well as the pharmacy benefit managers, which you'll often hear me refer to as either payers or PBMs. This is what you'd normally find the flow for most retail pharmacy drugs or self-administered drugs. However, when you have drugs that are administered in the physician's office or hospital, typically there's a little bit of a different flow. And we call that the buy and bill distribution and reimbursement system. So similar to the last slide, you want to focus on the relationships with the wholesaler, the hospitals or physicians' offices, as well as the payers. So some of those key channel participants, we already mentioned the distributors or wholesalers. In the US, depending on your product, you could have an exclusive distributor, or you could have dozens of distributors. It all depends on your product. What we call the big three wholesalers, which have over 90% of the drug market, are McKesson, AmerisourceBergen, and Cardinal Health. So those are key partners that you'll want to pay attention to. Many retail pharmacy products have 15 to 20 distributors. Also, depending on your drug, again, you may focus on retail pharmacies. Retail products are typically stocked in thousands of pharmacies. The key players there are CVS, Walgreens, Rite Aid, and Walmart. But there are many, many other important chains. If your drug requires a specialty pharmacy, right, you'll need to focus on them. That's typically for specialty medicines. And, different specialty pharmacies work well with different payers. In the last slide, we showed some of that vertical alignment. So that's important to keep, to pay attention to. Group purchasing organizations, you may or may not contract with them. Typically, group purchasing organizations will negotiate commercial discounts with manufacturers on behalf of their members. Depending on your product and the competition, you may or may not contract with GPOs. And then there's pharmacy benefit managers, very important. These are very, very large companies that are managing drug formularies. And they negotiate with dispensers on behalf of the health plans. So the big players there are really Caremark, Express Scripts, and Optum. Those are the three largest. So in the US, we have multiple benefit types. I'm going to focus on the two that are most important for drugs, and that's the pharmacy benefit, which was that first product flow that we saw. Pharmacy benefit is designed specifically for dispensing drugs. It's typically for self-administered drugs. It's typically managed through PBMs. And what's really nice is there's immediate benefit verification. So what that means is a patient walks into the pharmacy, they find out exactly what they have to pay before they're handed their prescription. On the medical benefit side, it's a little bit different because it's not really designed for drug dispensing. However, it is used for drug dispensing for products at hospitals, physicians' offices, and clinics. But it's really designed for, patient visits, seeing the doctor, having services like X-rays and whatnot. It's not as precise. It has variable processes. And unfortunately, the claims are processed after the drug administration. And this can be very difficult for patients because they don't always know what their actual cost will be for the patient until after the procedure is done. So this is what health insurance looks like in the United States. Not everyone is covered. About 9%, a little less than 9% of people in the US are not covered. But for those that are insured, the vast majority are covered by commercial insurance, which means private companies, as opposed to the government. And most of those are employer-sponsored health plans. So what that means is when you go to work, it's your employer who is providing that health plan, and they are determining with the health plan what your benefits are going to look like and what your financial responsibility will be. When we look at the government insurance, a little more than half of it's about half and half Medicaid and Medicare, with a little bit of that being the Veterans Administration. So Medicaid is for lower income, Medicare is for an older population. So one of the things that you'll find in the US is that the payers use drug utilization management techniques. So what they're trying to do is they're trying to lower their cost. And so here are 6 of the common things that they do. One is formulary tiering. So they'll place drugs into different tiers, and each tier will have a different patient financial responsibility because they want to incentivize the patient to use the drugs that are less expensive for the payer. They have prior authorizations. You'll see this sometimes class-wide, sometimes for specialty or very expensive drugs, they might be a little more complicated. So the physician may have to do testing and submit information to the payer in order to get a patient approved for the therapy. There's also step therapy, or sometimes referred to as step edits. This is where the payers will require a patient to try one medicine before they're willing to pay for another medicine. So often you might find this if there's a generic product or a less expensive product, the payer may require that first. And some people call this a fail first policy because the patient will have to fail that product before they can take another drug. Payers have exclusion lists now, and I'll show on the next slide some examples of that impact. But that basically means they won't cover a drug. They might have quantity limits. They may limit how often the drug can be dispensed, or perhaps the amount that can be dispensed with each dispense. There's also generic substitution, where some payers will require patients to use a generic when it's available. So here's an example, a very basic example of a common 4-tier system. So you might have tier 1 would be your generic products, and you might have a low copay of $10 or $15. Tier 2 would be preferred brands. Typically, if you want to be a preferred brand, you either have to be the cheapest one out there, or you have to negotiate and discount for it. So you might have, let's say, a $30, $35 copay. Non-preferred brands would be your typical other brands that haven't negotiated or are not necessarily the least expensive in their class. And you might have a $50, $60 copay there. And then specialty medicines are sometimes in a different tier by themselves because they're much more expensive. And sometimes you'll find that even if you have copays for patients, which are flat dollar amounts, specialty medicines might have co-insurance, which means the patient is responsible for a certain percentage of the cost. Also, I told you I would show you a little bit about exclusion lists. So this is a chart showing the big 3 PBMs and how their exclusion lists have changed over time. So 10 years ago, only Caremark had an exclusion list and it had only a few drugs on it. And today, the 3 biggest PBMs have exclusion lists with around 600 drugs excluded from coverage. So another thing to really be aware of is that we have a lot of government pricing programs within the United States. So I'll show you a few of the biggest ones. So one of them is the Medicaid Drug Rebate Program. And this requires manufacturers to pay a rebate for all of the drugs that are dispensed to Medicaid patients. These are very complex calculations, and there are major penalties if you don't pay them correctly. So these are typically monthly rebates that are paid. However, some of the claims can be submitted up to 6 months later. So we have what we call lag in some of these. There's also the federal supply schedule, and this is for specific federal government purchasers. So the Veterans Administration, Department of Defense, and a whole list of other smaller eligible government purchasers. This is typically an upfront discount, so it will likely be administered by distributors, and then the manufacturer has to reimburse the distributors through chargebacks. And then we have the 340B program, which is designed to give discounts to specific entities based on eligibility criteria in the law. Many hospitals are 340B entities now as the law has changed. More and more are getting covered. This is required for any drug that is covered by Medicaid. And these, like the federal supply schedule, are upfront discounts administered by the distributors. These are probably the 3 biggest programs. And to calculate all of this, there are a lot of government pricing calculations. I won't go through all of them, but I wanted to include the slide so you could see some very basic information on these calculations. These are not all of them. These are probably the most common. Typically, what I would recommend is that you would either need your own internal team to manage these calculations, or you can outsource these to vendors that will do the calculations for you and have a lot of experience in the area. Another thing that I find very, very important in the US market is to understand that the price you set is not necessarily what your net price is going to be. There are many forms of discounts and fees, and it creates a gap in your gross to net sales. So some of them might include if you give prompt pay discounts, which are common in the industry, you'll have to pay fees to your distributor. If you have specialty pharmacies, you might be paying fees to them. When you launch products, or depending on your product type throughout the year, you might give discounts. Those would impact your gross to net. Any payer rebates that you're giving to PBMs or health plans, your Medicaid rebates, and other government programs that are listed in here, any institutional contracting that you do. Oftentimes, we were talking about the tiers earlier. Oftentimes what manufacturers will do is they will have savings cards for your copay assistance. So if a patient would have to pay $60, sometimes the manufacturer will have copay cards so that that brings the patient's responsibility down and they have to pay less. So it's really important when you're looking at the types of discounts that you might give out, it's important to understand how those discounts impact your gross to net. But more importantly, focus on how does this discount change my access to get this drug to patients? How does this change my profitability? How does this impact my government pricing calculations? Because it will. And also, how does this impact the reimbursement that my dispensers, my pharmacies, hospitals will get from the payers? Because a lot of this will impact their reimbursement that they get. So in summary, I really want to end this by saying, although it's complex, you can be successful in the United States. Remember that. Do not get discouraged. You can be successful in the United States. Arigatou gozaimasu.
スティーブンさん、ありがとうございました。続きまして、パネルディスカッションと質疑応答に移りたいと思います。ここからはモデレーターとしてシミックホールディングス CEO 補佐の武田秀俊様が進行されます。また、パネリストにはスティーブン・プロジャンスキー様に加え、英気コンサルティング LLC プレジデントの英気則和様、リンク J 事務局長の高橋俊一様にご参加いただきます。それでは高橋さん、どうぞよろしくお願い、武田さんどうぞよろしくお願いいたします。
はい。矢沢さんありがとうございました。スティーブンさんありがとうございました。スティーブンさんのお話を聞かせていただいてて、今日はちょうど日本で3月3日ということで、ひな祭りの日なわけですけども、昔私も家でひな祭りを並べてて、どこにどの人形があるのかなと思って考えてたんですけども、それと同じで、スティーブンさんの話聞いて、こちらのサプライチェーンも何段、ひな壇があるのかなと思うぐらい複雑な話で、非常に複雑なことが分かりました。ありがとうございます。そういう意味では、多分それぞれのスライドを皆さんも見ていただいてもお分かりになりますように、多分どのセグメントをとっても非常に複雑で、それでは最後にスティーブンさんがおっしゃっていただいたように、エクスパートがいるから、皆さん適切な方を選んでくださいねっていうアドバイスが一番私には分かりやすかったなと思います。ただ、皆さん、このようにただしこのサプライチェーンっていうのは非常に興味深いトピックで皆さんいろいろと質問終わりだと思いますので、まずは会場におられるパネリストの英樹さんと高橋さんからコメントと質問をいただければと思いますので、よろしくお願いします。
英気でございます。スティーブさん、どうも今日はありがとうございました。非常に複雑な話を分かりやすくまとめていただいていると思います。まだだけども複雑でなかなか分からないと思うんですね。私、アメリカに来て今8年になるんですけども、ニュージャージーに住み始めてですね、いろんな経験しました。それでもまだ全容が分からないんです。で、例えば、うちの妻が糖尿病予備軍になったんですね。で、まさに今、スティーブンさんが言われたステップセラピー、を適用されたんです。で、私は、高価な、非常に効き目が鋭い糖尿病薬を使ってくれと言ったんですけど、違いますと。アメリカではステップセラピーというのがあって、メトフォルミンからスタートしますと。それで毎日1万歩歩いてくださいと。これを1ヶ月やりますと。これでダメだったら次に行きましょうということで、なかなか我々が日本で経験したような薬を使ってもらえないというのがありました。で、そういう意味でもスティーブンさんの話を聞いて、やっと理解できたなというところがあります。それで早速なんですけども、スティーブンさんにちょっとご質問したいんですけども、スティーブンさん、currently it's very hot topics of IRA, Inflation Reduction Act, that was enforced by Biden administration. Also among our Japanese friends, we are talking about a lot about IRA. And what would be impact to the stakeholders for the payers and hospital, patient, and pharmaceutical company? Would you please explain this?
So as with probably any regulation that gets added, it adds more complexity to the US market. So I'll start with the patients because there's a lot I like about the IRA in terms of what it does for Medicare patients. So it's important to understand a lot of the impacts are to Medicare. So it reduces the maximum out-of-pocket costs that patients have, which is fantastic. It reduces the cost of insulin for patients. It eliminates the copay completely for adult vaccines. So there's a lot of really good impacts for patients. For manufacturers, for some manufacturers, it's going to have some interesting impacts. So there's been a lot of talk for years about allowing Medicare to negotiate with manufacturers. And so the IRA does that. What's interesting, though, is that it's so that I should step back a second and say the implementation is going to be over 6 years with the IRA. So the impacts will not be felt immediately. So what's really interesting is that it will allow Medicare to negotiate. Actually, it will require Medicare to negotiate with manufacturers, but that will start in 2026. And it's going to limit the number of drugs that they negotiate. So in 2026, they're going to negotiate 10 drugs. And by 2029, it's going to be up to 20 drugs. So these are going to be some of the top selling drugs. So a lot of companies won't really see impacts to that negotiation themselves. However, that might also get commercial payers to try to negotiate for those particular drugs as well. But the other thing is, and I forgot to mention this on the patient part, is that patients, the payers are going to be required under the catastrophic coverage. They're going to be required to cover a larger scope of services, larger cost. And so what I think we'll see is that's good for patients. But I think what we'll see is that will push payers to try to negotiate more with manufacturers on the commercial side, because they're going to have to pay for that somehow, right? And I think manufacturers are going to have to negotiate a little bit more with commercial payers on that. So there's also mandatory rebates for drugs that increase in price higher than inflation. That's something we have not seen in Medicare before, but that's actually very similar to what we see in the Medicaid rebate calculations. There's actually a calculation, we call it Medicaid rebate penalties. So I think it'll be fairly similar. I haven't seen the actual calculation, but I think it's fairly similar. So it's something we've seen before in other programs. So I would recommend definitely keeping an eye on the IRA and changes that are likely to come in the future. I would expect further changes at some point.
Thank you so much.
Thank you. 高橋さん、いかがでしょうか。高橋さん、いかがですか。コメントとご質問等ありましたらお願いします。
はい。聞こえますか。
はい。
スティーブさん、ありがとうございます。非常に、複雑だということが本当によく分かってますね。私はサプライチェーン、等々の専門家ではないので、どちらかというと、今日見ている方々の中の、あまり馴染みがない方、素人側からですね、少しコメントをさせていただければなと思います。それで、複雑さということはよく分かったんですが、少し私は患者さんの立場から、そういう薬へのアクセスっていうことで、まず質問があるんです。先ほどの、Payer Drug Utilization Management っていうところでも、例えば、Exclusion リストであるとか、Quantity Limit であるとか、様々な影響っていうものを指摘をされていましたけども、もう一つあったのが、ペイラーの、統合が進んでいる、バーティカルインテグレーションですね。っていうことがありました。それで、なんとなく素人目に考えると、大きくなることで、価格交渉力を持つということはよくわかるんですけども、逆に影響力を持っているプレイヤーが、どんどん大きくなっていくと、例えば患者さんにとって薬の選択肢が減るなんていうことにはならないんでしょうか。
The consolidation. So I think there's some benefit and some cost to the patient with the consolidation in the industry. I really like the idea of population health and focusing on wellness. One of the reasons why health systems are expanding so much is because with the Affordable Care Act years ago, there are certain quality standards that they have to meet, and they get scored, and it can impact a variety of different things for them, including reimbursement, as well as readmissions into the hospital. So one of the problems they faced is when a patient would be discharged from the hospital, the health system had no control over what the treatment was for that patient. And so patients could be readmitted through no fault of the hospital. And so they started purchasing doctors' offices, and they started purchasing other hospitals and health systems, really to get control of that population health. And it allows them to create system-wide protocols, which I think are very good, because now they're looking at a much broader base of patients when they're deciding what should the right therapies be. But depending on the health system, they don't always, sometimes the drug selection can still be selected by the individual doctor. It's not always just a list from management in the health system. On the payer side, it could, I think, definitely could cause an issue for patients, especially if their employer uses a PBM that cuts out a medicine that they need. This is often happening with specialty medicines. That could definitely hurt patients, there's no question. And the more power that these payers have, the less power everyone else has to influence them to cover drugs, whether it be on their plan or as exceptions for patients. So there's some of the consolidation is certainly good, and some of it can be bad for patients.
Okay, thank you. もう一つ、多分スティーブンさんともしかしたら英樹さんにもお伺いした方がいいのかと思うんですけども、エクスクルージョンリストっていうお話がありましたけども、こういうのがどんどん進んできて、かなり劇的にその数が増えていたように見えたんですけども、これは例えば新しいモダリティとかで、 薬の単価が高くなったことによるということの理解でいいんでしょうか。それでもし、この患者さんがそういう高額医療、例えばジーンセラピーとか、そういうものにアクセスをすることっていうのは、どのぐらいこうフレキシビリティがあることなんでしょう、アメリカにおいては。
そうですね。そうだね。Exclusionです。increasing. So reason is limit price increase and reason to continuous. So it's like since having a quite expensive limited.
So yeah, I think a lot of the expansion of the exclusion lists is could be because maybe there's competition within a disease state. There could be multiple drugs, and the PBM might decide we'll try to get a big discount from one of them to exclude the others from coverage. So that's a big reason why that might happen. It might happen if there are, generic alternatives. One thing to keep in mind though is that typically there are appeals processes. Being on the exclusion list doesn't mean that no patient will ever get it from that PBM, but it makes it a lot harder, and it puts a big burden on the healthcare provider to go through the appeals process to try to get the patient on. But typically, you see this with various therapies. I'm not sure if we'll see that much with gene therapies because they're very innovative. Some of them claim to be curative, which is amazing. What we probably will find with some of these very expensive drugs is that there will be other restrictions, if not excluded. There will be other restrictions, especially the more expensive the drug. We'll probably find that they might restrict it to patients that are maybe a certain, have progressed to a certain degree on the disease, because maybe they just can't afford to pay to cure everyone, right? Or to give these treatments to everyone. Or there might be other things that they do. And they may go back and threaten manufacturers that they'll exclude them if they don't offer them big discounts. It's possible.
Just a follow-up question, but going forward, will you expect the acceleration of the number of drugs to be excluded from here, or like the pace will decelerate, or how do you expect? What's your expectation?
So I think we might find I don't know if it'll accelerate because it's gone up at a pretty high rate, but I think it will continue to grow. I think we're seeing biosimilars come on the market. So, a lot of the brands are giving big discounts to compete.
Could you repeat it again? Because, the connection is not good.
Oh, sure. I think that it will increase. I don't know if the rate of growth will accelerate because it has been such a high rate, but I think we will continue to see an increase in drugs on the exclusion lists, especially with biosimilars hitting the market. Now, granted, a lot of the brands are discounting at high rates to compete with the biosimilars, but I think we might find that either brands or some of the biosimilars might be excluded from certain PBMs based on that pricing. And that PBMs may just choose one or two, and that's it.
And also, you mentioned that like everybody mentioned that the supply chain is very complicated. But for the next 5 to 10 years, like how do you expect the landscape? Will that be more complicated, or just a little bit simpler, or how do you think?
So I think it's going to get. It always seems to get more complicated. I think there will always be more complexity. But, as an industry, we grow with it. Right? Don't let that discourage you. I think in the next few years, the next 5 to 10 years, especially with gene therapies and cell therapies coming out, more and more personalized therapies coming out, I think what we're finding is they're more complex, both the storage requirements and transportation requirements, right? A lot of them are ultra cold or cryogenic. A lot of hospitals, a lot of them need to be administered in the hospital, and they might have complex, you might have to spend a week in the hospital or a few days in the hospital to get the certain therapy. You might not, depending on the therapy. Some of these drugs, they're personalized, so you have to take cell samples from the patient first. And especially with these cold, cryogenic or ultra cold products, it's going to be more and more difficult because a lot of facilities really aren't set up for that, right? So in the past, a lot of health systems wanted to create infusion centers and get some of these infusions out of the hospital itself. And now we're going to find that we're going to have to move back into the hospital or have facilities that are very close to the hospital. These facilities are going to have cryogenic tanks or liquid nitrogen tanks potentially. It's going to get more complicated if a patient doesn't show up for therapy, right? When do we start thawing the product? What happens to the product if we start thawing it and the patient doesn't show up or is delayed, or the infusion chair doesn't become available when we thought it would be? What do we do? What does the hospital do, right? From a manufacturer standpoint, how do we address that, right? And these are very expensive medicines typically. So I think it's going to get a lot more complicated, but I think, as always, with human ingenuity, we'll find solutions, right? As manufacturers, the health systems will find solutions. I think the industry will find solutions.
So with all the creativity human have. So, for example, if you have all the power to change the world or supply chain, how do you make, what's the one thing you would like to take to make the pharmaceutical supply chain simpler, if I may say?
So, I don't know if this really technically is supply chain related, but if I could choose only one thing to change in the US healthcare system, it would be the patient financial responsibility. I would really want to streamline that. And make it reasonable. I mean, I've seen statistics in the United States of the number of patients. I don't remember the percentages off the top of my head, but percentages of patients who go without their therapy because it's expensive. And so they skip therapy. That's bad for their health, right? That's bad for the overall costs to the country of healthcare as their disease progresses. Patients, not seeing doctors when they should. People going bankrupt because of the cost of therapy, whether it's drugs or otherwise. So if I had to choose one thing, that would be it. But there's a whole list of things I would change. I would want hospital reimbursement to be simplified, or all reimbursement to be simplified. We have many different calculations to determine what the reimbursement is for different settings. This is a pet peeve of mine, also focusing on the patient. Patient can go in with an emergency, go into the hospital, and let's say just have emergency surgery as an example. And they'll get a bill a few months later, they'll get a bill from the hospital for the emergency room. They'll get a bill from the hospital for the surgery, but then they'll get a bill from the anesthesiologist, right? Who administered the anesthesia, right? They'll get another bill from the surgeon. Why are these multiple bills? And you don't know this as a patient. Maybe the hospital is in your health plan network, and maybe that surgeon is not, even though that surgeon works for that health system. Now what? And now these patients who just had some sort of emergency, now they have to worry about these ridiculously expensive costs. Now, oftentimes you can appeal that, but now you have to fight with your insurance company to get it covered. I would change that.
Yes, simple bill might be a good solution. And I assume you are not running for president for 24. So will this be healthcare be a big issue for next presidential election? If so, what would you expect to be the topic?
So I think healthcare often is a topic. I think, we hear Medicaid for all thrown out often. Drug pricing is everyone's favorite topic to talk about. I think that in particular is is a little misunderstood. Everyone talks about the list price of the drug, right? And I showed a slide earlier about gross to net changes, how there's such a big difference between your gross price, your gross sales and your net sales. And so what we find in the US is list prices typically increase across the industry, not every drug, but across the industry, they typically increase every year. And even so, in some years, the net prices go down. And so it's really interesting. Everybody likes to talk about that list price because that's what angers people. I also think it's a little bit of misunderstanding in what is actually costing Americans more year over year in healthcare spend, and what are the big differences between the US and other countries. Yes, we pay more for drugs, but that's not the biggest difference between the US and other countries in terms of healthcare spend. And even year over year, it's not the biggest factor in the increase in healthcare spend in the US. Oftentimes it's hospital services and other administrative services that actually can be up to 5 times more, add 5 times more to healthcare spend than drug prices. So even when you look at the list price. So I think that will likely be a topic. I think those are probably the big ones. You know, I have another pet peeve a little bit of copay accumulators. I think they're bad for patients. I think they're bad for choosing therapies. So those I think might be topics. We saw some action from the government on them, but they're really growing. So I think that's another thing.
Good.
Yeah, thank you, Steve. Yeah, we are listening a lot of problems in U.S. health insurance system, supply chain system. But one thing I like it very much. 日本語で言いますかね。一つね、非常にいい制度っていうのは、私の妻が高血圧と高脂血症なんですよ。で、コロナの時には1年間も全然病院に行かなかったんですけども、薬はね、ちゃんと3ヶ月と6ヶ月、コロナの時は6ヶ月だったんですけども、ちゃんと家に送ってくるんです。で、それもいいのはホームデリバリーなんですけどね。で、そこで、今日の8時にはニフェディピンを飲みなさい。今日の10時にはアトルバスタジンを飲みなさい。一方化放送されてるんですよ。それがね、3ヶ月分全部来るんです。ですから、昔、うちの妻は月火水木金土で薬を全部で4錠飲んでるんですけどね、こう別々に入れてたんですよ。それが、ね、全然ない。で、それはもうファーマシーの方で、保険会社の方なんですけどね、そこが全部それを準備してくれてるっていうので、それはね、私は非常に助かってます。That is a very good point, good, benefit of United States.
いやパネルだけでも質問が止まらないんですけど、ちょっとここで会場およびオンラインで参加されている方からも質問いただきたいんですけれども、まず会場からいかがですか。
While we're giving the mic out, I just wanted to also mention another benefit in the United States is drugs. Typically, we have more options typically than other countries, and drugs come out a lot faster in the United States than most other countries. So there are a lot of benefits as well. Yeah.
Thank you so much for your wonderful presentation. It is so useful for me to understand the complicated system. で、日本語でいきますけど、鈴木幸夫と言います。私はですね、私はですね、産婦人科腫瘍を専門としているフィジシャンなんですけれども、今日どんな話されるか分かんなかったんですけれども、来てみたらまさに僕が今やってる研究の全く同じとこなんですけれども、私は保険データをリアルワールドのデータを分析しているような仕事を今してまして、非常に複雑なものを見て研究をしてるんですけれども、私はフィジシャンの立場でサプライチェーンも非常に重要なんですけど、結果的に患者さんが良くならなければ意味がなくて、やはりアメリカでも非常に問題になっているのはやっぱり高額なので、結局ベストな治療を提案してもですね、患者さんが処方を受け取らない。で、先ほどお話しあったように、もらっても定期的に来ても飲まないっていうことがやはり問題で、そのあたり何かこのサプライチェーンの中で、最後のフィニッシュのところだと思うんですけれども、何か工夫をされているようなことっていうのは、日本の場合にはですね、みんな真面目なので、結構薬飲んだりとかするんですけども、やっぱり
コストが高いとかそういった問題もあって、何かこう、独特な工夫みたいなものがあるんでしょうか。
To the cost of patients.
Yeah, that will supply the point of
So I will say it's very difficult for a drug manufacturer, especially from a supply chain standpoint, but it's very difficult for the drug manufacturer to actually control patient prices because we don't set the price to the patient. The price that the patient pays is determined by the insurance company, the health plan, with the plan sponsor, which typically is the employer. So as an employer, you might you'll select a health plan for your employees, and you'll negotiate with the health plan to determine what will those copays look like, or what will the coinsurance look like for drugs, right? And so that's really important to understand is that the drug manufacturer has no control over that, except when we give copay assistance or other, other programs such as PAP programs, which are free drug programs, right? Or copay cards to help the patient. What we find now, though, and I mentioned I have a pet peeve of copay accumulators. What we're finding is that some of the payers are now trying to fight back against copay cards because they believe that encourages patients to use more expensive drugs than the ones that the payers want them to use, which are cheaper. So what they started doing is they call them copay accumulators or copay maximizer programs. And what it does is that any money from the manufacturer copay assistance no longer, if you have that program, no longer counts towards the patient's deductible or their out-of-pocket maximums. And so now the payer is keeping that money that the manufacturer's giving, but that money was intended to go to the patient. And so, it's a lot of back and forth here, it seems, between manufacturers and payers. The payers want to control the drug formulary. They want to choose what drugs patients get. And a lot of the time that coinsurance or that copay is part of, or at least the tiering systems is how they're trying to control it. But ultimately, it's really the employer and the payer that are controlling the price the patient pays.
Yeah, before closing this session, I'd like to take one question from the online participants. And his question is, even in the new modality such as gene therapy, cell therapy, will the supply chain still complicated, or will that change? How do you think?
Oh, yes, it's still very complicated. I think it will likely be even more complicated because as these drugs get more and more expensive, right, we're going to have to find new solutions. So very expensive drugs, I've seen a drug out there that has a payment plan for the payers where they pay for the treatment over multiple years, right? So that's even more complicated, right? And you have to design your system around that. What does my supply chain look like?
Like monthly mortgage.
Yeah. So you have to design what's your supply chain around the drug that you have. And different drugs within the same company, you might have different supply chain systems within your company for different drugs. And that's okay, right? You want to customize it for the drug because ultimately you want to do what's best for the patient. How do I get the patient on this treatment? How do I get them on as quickly as possible so that they get the best health outcomes? How do I design a system that gives them access at all to it, right? But enables them to stay on their therapy to get the most benefit and get those good health outcomes. Ultimately, right, I always come back to what is the patient journey and how do I design my supply chain system to ensure that those patients can get the treatment that they need?
Thank you. スティーブンさん、ありがとうございます。
武田さん、
はい。
質問、もう一個質問していいですか？
特別に高橋さんだから。はい、どうぞ。
聞こえます？
はい、大丈夫です。聞こえます。
聞こえないかな？止まっちゃった。
聞こえる。
固まっちゃった。聞こえてる？じゃあ私の方からもう一個質問なんですけど、はい。日本から今日聞いている方々の中には、例えばベンチャー企業であったりとか、小さな企業で今後アメリカへの展開を考えているような方々もいると思うんです。 それで最後のキーメッセージのところでスティーブンさんが、インベストメントが必要だっていうことと、専門家を見つける、雇うことが必要だっていうことを書かれていたんですけども、そのインベストメントという観点から、専門家を雇う以外に必要なことってありますか？
Yeah, I think wait for investment companies. So I think, yeah, it's very important to understand the market, right? Whether you're a startup drug company, an investment company that wants to invest in drug companies, I highly recommend that you invest in your business, right, to understand the market, whether that's hiring experts in the US, whether that's employees, consultants. It's really, really important to understand the US market. And the US market is very different than other markets. So yeah, I would say yes, it's very important to invest, regardless of what type of company you are. And if you're entering the US market, it's going to take some investment. But you can succeed.
Okay, that means you suggested to invest to understand the market, right?
Well, yeah, to understand the market, and if you're a drug company, to operate in the market, right? It's important that you have people, whether they're on staff or consultants, but typically I would say on staff or both, really. You want to make sure you're setting things up properly and that you continue your operations properly.
Thank you.
時間もだいぶ押してきましたので、スティーブンさん、英樹さん、高橋さん、パネリストの皆さん、ありがとうございました。予想通り複雑なトピックだなというのと、我々には専門家がいてよかったなと、そういう意味ではもし皆さんのご希望があれば、2回目、3回目もやりたいなと思いますので、ではここで矢沢さんにお戻しします。
はい、ありがとうございます。スティーブンさん、本日は、米国の医薬品サプライチェーンについてご講演ありがとうございました。クロージングに移りたいと思います。高橋さん、どうぞよろしくお願いします。
はい。改めまして、リンク J の高橋です。本日は貴重なお話、または様々なパネリストの方々の意見ありがとうございました。本当に日本とはかなりそのサプライチェーンのもう幅が広くてですね、日本にないようなことも多くて、その複雑さっていうのを改めて、感じたところです。特に英樹さんのご経験なども含めてですね、日本との違いっていうものをよく感じたなと思います。それで、このようなトピック、今までリンク J の中でも実はあまり多くなくてですね、でもやはりそのビジネスをアメリカで展開をしていくっていう中では非常に重要なポイントなんだろうなというふうに思います。そういう意味においては、また機会があればですね、こういうトピック、今、武田さんもおっしゃられましたけども、ぜひ取り上げて、様々な、新しい、その先ほど言ったマーケットを知るっていう観点もですね、広げていけたらなというふうに思います。本当にありがとうございました。で、クロージングということで、今回そのニューヨークと日本橋をつなぐという形でですね、ウェビナーを実施をいたしました。で、なかなかそのイーストコーストと日本だと時間的な部分も時差もあってですね、少し日本の皆様、参加していただいた皆様にとっては少し朝早い時間ではあるんですけれども、やっぱり生でいろんな話を直接聞けるっていうのが、非常にいい機会じゃないかなと思っています。また今後ともですね、こういう機会、また継続していきます。そして、その冒頭にもありましたけれども、横浜市さんとリンク J のこのライフサイエンスラウンジ、あとニューヨークシティですね。これは、単に発信をするだけということではなくて、様々な日本からベンチャー企業さんが進出をしていくときに、メンタリングの場に使っていただいたりとか、またちょっと行ったときに利用していただくとか、そういう意図も含んでいますので、ぜひこういうところをきっかけに、また我々の活動というものも広げていきたいなと思っています。 ということで、本日は本当に皆さんご参加いただきありがとうございました。